So Srinivas, can you help her?
I have unmuted myself now.
Okay.
Now, would you like me to start?
Yeah, good afternoon to you, Jill. We can't see you though. I don't know if your video is on.
It should be.
We can hear you though. Yeah, but we can't see you.
Can you hear me also, Raja? Good morning.
Yes. Good morning. Good morning, Dr. Das.
अन्नाज कसे आहेत?
Good morning, Dr. Das. I'm good. How are you?
Fine, thank you.
Me bari hai. I hope that's the right one.
Right.
So Jill, can you see the slide right now? And
Raja, can you start?
sure, you can hear me.
I can hear you. Sorry, I am trying to get my slides showing as well.
So, okay, if you maybe you can try uploading your slides now. If not, we have your slides. I think Rohit has the slides, but it would be good if you can try uploading your slides now.
I can play her slides if she wants, but I think let's get started, Raja. It's already 11.
Yeah, so only thing is we are unable to see her. It would be good to see. Okay, so welcome everyone. Good morning, good afternoon, wherever you are. Welcome to the first lecture from IHOPE, which is hopefully going to be a monthly series on different topics of public health, big data, and health economics. I would request Rohit now to introduce Jill and start the first lecture of this series on basics of health economics.
Good morning, good afternoon, good evening, everyone. And this is the first series, thanks to Raja and his team, who have put a lot of efforts to get this series started. And the first session on this series is like basics of health economics. And who could be a better speaker than Professor Jill Keeffe, who has worked extensively in public health for last 30-40 years. And Jill started her career as a teacher and then subsequently went to do her PhD and from University of Melbourne, and subsequently I think she has worked extensively in the area of children with special needs, as well as in areas of prevention of blindness, multiple areas. And recently, as all of you know, there was a vision loss expert group started to, which came with the formation of many ophthalmologists and optometrists with interest in ophthalmic epidemiology. And basically, it was a part of Global Burden of Disease Group. Global Burden of Disease Group started in year like 2007 sometime, and Vision Loss Expert Group was a part of that to advocate for visual impairment and blindness across the world. And as you know, for advocacy, you require data on economics also. So this group came with series of data on health economics, as well as the data on blindness and what's happening with that for past almost a decade. And we have data in 2010, then we have data in 2015, and now in 20. And Jill is a prominent member in that vision loss expert group. So who can tell you better than Jill about what's going on with vision loss expert group data recently and what kind of advocacy they are into it. Recently, we have even World Report on Vision, and recently, 2 days back, the Lancet Commission was on blindness was there in press, in publications. So all this data, including the economics data, is important for advocacy. And I would like to ask Jill to share her thoughts about the economics, basics of health economics, especially related to blindness. Over to you, Jill.
Thank you, Rohit. Oh, gosh.
And just a housekeeping announcement, if you have any questions, you can put on the chat box and we can take it at the end of the session. We have 1 hour to go. Over to you, Jill.
Thank you, Rohit. Can you see the slides now?
Yeah.
Ah, great. Okay, thank you. Let's start, and thank you, Rohit, for the introduction. Sorry, I'll just get, yep. So just to outline, there are 3 components of the lecture that I would like to present today. And the first thing is a global overview of vision impairment and blindness, and taking the data, as Rohit had mentioned, about the global burden of disease study. So in looking at health economics, there are these 3 components that we need to look at. And firstly, having the prevalence, the numbers, the details about the causes of vision impairment, so that a critical part of having the data to be able to do that. Secondly, we're going to look at the measures, the tools that are used to look at the impact of vision impairment. So firstly, the DALY, looking at disability, then the QALY, about participation for people with vision impairment and blindness. But those tools can be used for any area of health. Then we're going to look at health economics and look at some of the methods that can be used for planning and evaluating ICARE. So firstly, we need the data, and it's needed. Sorry, is that okay? That we need the data to look at the... I'm sorry, is there a problem?
I think you're fine, Jill. Rohit, were you trying to say something?
No. I think they had some internet breakup, so it's okay. Go ahead, Jill.
Jill, go ahead. Yes. Sorry.
Thank you. No, I'm pleased it's working. So we need to look at the needs of people with vision impairment and blindness, so we can plan and monitor ICARE. And the data are needed for that, planning, monitoring, evaluation at global, country and regional levels, but also certainly globally. The World Health Organization uses the global data to be able to look at what's needed, looking at change, for example, like Vision 2020. At a country level, for a country to look at planning, policy, and so on. But also the data usually comes from regional levels, so that, that's really important, to look within a particular region, what is needed. And then obviously population data, and looking at the prevalence of vision impairment, the numbers of people, and then the things like age, gender, and the use of services for people. So these are the things that are needed as part of certainly looking at health economics. The data, as I mentioned, will be, they've been using the global burden of disease, an incredible thing that was set up by the Institute of Health Metrics and Evaluation in the United States a couple of decades ago. And vision is just one of the 135 major causes of diseases and injuries and the consequences. So it's a massive study. And there are 7 super regions, and there's subdivisions into 21 regions in the global burden of disease, and incredible amount of data. have been collected and used. And as Rohit mentioned, a vision loss expert group was formed and is certainly very active. So in the global burden of disease, vision impairment is measured, or the categories: blindness, moderate and severe as a category, and mild vision impairment. And that was not there in the early stages, but it has been added because there are now data on mild vision impairment, collected enough to use. So it's prevalence and causes, and the baseline is 1990, and the data were collected and reported for 2010, 2015, and Rohit, I think, mentioned for 2020 data were published. The regional data haven't been published yet, but certainly the data on prevalence and causes were published in January this year in the Lancet Global Health. And in the last lot of data for 2020, an enormous amount of data are collected. Not all are eligible, and we'll look at the eligibility for being included, but 528 sources. Most of them are from publications, but others, like the Rapid Assessment of Avoidable Blindness, from the RAB website. So not every country has data, but there was, data from 98 countries and the regions, looking at prevalence for the total population, and also importantly for people over 50 years of age, and the numbers for all ages. And I'll be showing some of those. And so just looking at the categories, and as I mentioned, recently, mild vision impairment, less than 612 to 618, moderate vision impairment, less than 618 to 660, and severe, less than 660 to 360. And as I said, that moderate and severe vision impairment is that looked at as one group in the global burden of disease, less than 618 to 360, and then blindness less than 3/60. So as I mentioned, it was important for all the data sources that the data are reliable. We know we can count on it. And so the criteria that are used to look at what can be an incredible amount of data if you're searching the literature and looking at other sources. But the criteria include that it must be representative of the particular population in either the region or the country that is being included, so that we know the data that come certainly represent the particular area. And then prevalence measured for a particular population, and a lot of it is over 50 years of age, some over 40. Very few surveys that are done on children, but mainly over 50 years of age, obviously, where vision loss is more common. And then once a region has been selected, the particular locations where the surveys are conducted must be randomly selected. You can't go, yeah, these are nice places to go to, but randomly selected to be able to do that and to get the adequate numbers that you need for the study. And then importantly, once you have those regions, all the people of the age, for example, if it's over 50, are examined, and they provide information with the percentage who participated is important. It's rarely ever 100%, but did they able to examine and get data from most of the people? From that, the prevalence is calculated, so which is the percentage in the population looking at those categories of vision impairment. So sometimes people get a bit confused. Is it prevalence or incidence? So, prevalence is looking at the proportion in the population, and the incidence, new cases over, at least 2 periods of time, and it's most certainly prevalence, the proportion. The change, if you're looking at over a period of time, which we're going to look at a little bit later, is that change significant? And I'll show you examples of the prevalence and the confidence intervals that are used to look at whether the change is significant or not. But also across the 21 sub-regions and the 7 main regions, looking at differences within all of those areas. And looking also things like gender and age differences. So looking at the data, as I said, 1990 was the baseline, and the 2020 data on causes and prevalence have just been published. So looking at blindness, and this is for all age, where it was 3% in 1990, reduced to 1.9%. And as I mentioned, the confidence intervals are there to look to say, is that change significant? And we have the confidence intervals for 1990, 2.75 to 3.6. And if we look at that for 2020, they're separate. So we can say, yes, that change from 3% to 1.9% is a significant change. For moderate and severe vision impairment, and as I mentioned, mild vision impairment is only in the later studies, not in 1990. So a lot of the comparison is for moderate and severe vision impairment, a decrease from 3.8% to 2.9%. So looking at the confidence intervals, yes, there's a decrease, but not significant. There's data, obviously a lot of it, numerical data and graphs and so on. But this is just a nice diagram to look at. Firstly, there's global, the green column there, and then 6 regions. So the height of the columns is the difference in prevalence across those regions, and the change from 1990, this one diagram is only up to 2010, but like mentioned, there has been change. So certainly very good that the change has happened, but this also shows from looking at the high income countries to the left of this to the lower income countries, the last 3, Sub-Saharan Africa, Central and South Asia, and then North Africa and the Middle East, the much higher prevalence in those regions, but also there has been some decrease. So looking at the number of cases, the prevalence and the changes, and this is for all ages. So what we have: blindness, moderate and severe vision impairment, mild and uncorrected presbyopia. As the data are available for those regions, but I've included the global and the South Asia region because that's the region that includes India. So looking at the cases in 2020, and so this is the number, not the prevalence. So it's looking at the millions of cases. So in blindness, 43 million, and then of course, much larger numbers for moderate and severe vision impairment, mild and uncorrected presbyopia. And you know, that similar in moderate and severe vision impairment, South Asia, in moderate and severe and mild vision impairment. Then the changes, because we're looking at the number of cases, there's been quite large increases both globally and in the South Asia region for those categories. So numbers increasing quite substantially. Then the prevalence per, this is prevalence per 1,000 for those categories of vision impairment, and the change, and here positive because the change, you know, has been reduced. That we're looking at in that simple diagram, but and globally, no, not for moderate and severe vision impairment. It's very similar, but for the other categories, except for presbyopia globally, there has been a change, a reduction in the prevalence of vision impairment. So looking at the change over that period of time in older adults over 50, age standardized prevalence decreased by 28.5%, with the change, going from 25.8 cases per 1,000 to 18.5 per 1,000 in 2020. But besides looking at the total population, it's popular to look at, or possible to look at the differences between gender. And what we have for males is a larger decrease than was found among females. So, as I said, the things that we want to collect, obviously, the prevalence, the numbers, but we need to know not only regional, but about the people who are included in the surveys. What is the difference? Because obviously the implications that we need in planning and delivering ICARE. So that basically the reduction in prevalence was the reduction in cataract-related blindness in many regions, but certainly especially in the Eastern and Southern Asian regions. So some of those data, we've just looked at in the tables. So, important. But where prevalence has decreased, the numbers are increasing, have increased. So over those, the baseline at 1990, the 3 time periods that since then that the global burden of disease data were collected and used. So the numbers, blindness has certainly increased over that time. Moderate and severe vision impairment, quite a large increase in that. And similarly for mild vision impairment, but only the data for those 2 last time periods. Why have we got more people? If the prevalence is going down, why are the numbers going up? Certainly what that demands for ICARE, more people to service. So, massive issue, but part of it is sort of, for all of us living, life expectancy has increased, and it's sort of, increased obviously in those examples that are there. Some of them relatively small increases, but looking at India, 1990 life expectancy was 58, 2020 increased to age 70. And yeah, just through all of those. And I have to say, yeah, for Australians from 77 to 84, that certainly good news for individuals, but yeah, a real challenge in what life expectancy is doing, as I showed in that previous slide. Yeah, with the numbers increasing and quite substantially in the different categories of vision impairment. So the numbers are predicted to change, looking at what we know, what's happening with obviously the prevalence going down and life expectancy, for example, that the prediction from 2020 to 2050, quite an incredible increase from that 43.3 million now, you know, can increase to 61. And, you know, for those of us involved in planning, delivering ICARE, this is an incredible challenge in looking at the numbers that are there and what this is going to mean to be able to, you know, provide the services for just, you know, incredible increase in numbers. And it's across all the categories of vision impairment. So the World Health Assembly set a target, like was done with Vision 2020. The World Health Organization in 1999 set the target for 2020 of being eliminating avoidable blindness and vision impairment, that that was going to happen. Obviously it hasn't, but also in 2010, the World Health Assembly set a target to reduce the prevalence of avoidable vision impairment, that is the cataract and uncorrected refractive error, by 25% from 2010 to 2019. And looking at the data that we've presented, there has been a reduction, but certainly not necessarily to that extent, but it was looking at particularly the avoidable vision impairment and blindness. So we've looked at the numbers, but the causes obviously also important that we need to look at for the planning. So looking at the categories blindness and moderate and severe vision impairment, and world, and I've used again South Asia. So we've got the for both moderate blindness and moderate and severe vision impairment, the data for 1990 and 2010. So it's looking at, for each of the causes, what percentage is due to that cause. So that has it increased over time? Has it decreased? And so for blindness, the most common or the greatest percentage is for cataract. So that from the world data, 1990, 36.6% and 45.5%. So it's still the most common cause of blindness. For moderate and severe vision impairment, the numbers are smaller, but for uncorrected refractive error, it is the most common cause of moderate and severe vision impairment. So from the world data, some decrease in 1990 where it was just over 51%, down to 43% in 2020. And then not a lot of change in the other causes, there has been some. Interesting for age-related macular degeneration and blindness, decreased from 8% to 5.6%. And similarly for moderate and severe vision impairment. So some have increased in the percentage, some have stayed very similar. Looking at the decrease, for example, with glaucoma from the world, from 8.6% increased to 11%. Diabetic retinopathy, I think, is really interesting and important to look at because that is an increasing percentage. For example, the world for diabetic retinopathy 0.9% to 2.5. It's not a massive change, but yeah, it's certainly a change. And in South Asia, looking at the change blindness there, yeah, obviously really important. So similar pattern for moderate and severe vision impairment, an increase, and obviously related to what in many countries and throughout the world, increasing prevalence of diabetes. And then obviously other causes, the percentages are there for that. So just looking at the South Asia region, particularly the changes in causes of blindness. So the reduced prevalence, just to summarise, reduced prevalence was cataract, uncorrected refractive error, glaucoma, macular degeneration, and the residual, the group of other causes. But as seen in that table, the increase in prevalence of diabetic retinopathy. So it is one of the lowest percentages of causes of blindness, but the age standardized global prevalence has increased over those 3 decades. And obviously, as I mentioned, the prevalence and numbers of people living with diabetes, the numbers of people with vision impairment is likely to continue increasing. But the most regions with the greater differences due to diabetic retinopathy, the increases are in Asian and sub-Saharan Africa and North America, that those increases. So it's not a global change in all regions, but yes, it's certainly happening. And certainly in those lower income countries, one of the great concerns is the availability of ophthalmologists and the resources, whether that be equipment, whatever, for screening, for detection, but also obviously of management of diabetic retinopathy. So that's just an example of one of the challenges that we have. So looking specifically at the South Asia and Indian data, in 2015, India had the second highest number of people with vision impairment and blindness, over 56 million people in 2015. I have to say, we have the data for 2020 aren't published yet because, as I mentioned, only 2 papers with the 2020 data, the global paper on prevalence and causes. So these data that I'm presenting now are from the 2015. But looking at the numbers for India and then the South Asia region, the countries in that went from 8.75 in prevalence down to 5.74. And the prevalence reduced in all categories of blindness and vision impairment over that time period. But certainly looking at the 2020 data, that the South Asia region had the highest numbers. So the second highest, 2015, but this stage has gone to higher. The numbers there shown for blindness, moderate and severe, and for mild vision impairment, and the uncorrected presbyopia. So some incredible challenges within the region. So for the global burden of disease, the data, what have we learnt? That 90% of the vision loss is preventable or treatable, and a similar percentage in low and middle income countries. Yeah, and so we've got data for all ages, but certainly as we expect that about 3/4 of the people with vision loss are aged over the age of 50. And the percentage is higher among women and girls. That there's, that percentage is, well, 55%, it's certainly over half. So from the global prevalence from 1990 to 2020, the prevalence of blindness in older adults reduced differently by gender. So it reduced by 25% in women and 33.2% in men. Mild, moderate, so not only blindness, but mild, moderate and severe vision impairment, similar pattern for that increase in women. So for not only just looking at gender difference, but all of the things that we need about the data to look at having the data, and then what are the reasons? So what do we need to initiate to close the gap, for adults, children? How do we reduce both continue to reduce the prevalence, but certainly decrease the numbers? And obviously with aging of the population, so the populations in countries increasing, it's certainly giving us great challenges in what we need to be doing. So just finishing this part of the presentation, we've got those prevalence, which is reduced, but looking at the estimates for 2015, it's incredibly challenging looking at the numbers for both blindness and moderate and severe vision impairment. And, we now have the data globally from the global burden of disease for 2020. And we'll have, as I mentioned, there'll be papers published relatively soon for all the regions. So the whole point in why do we need the data, and how do we use it, looking at the challenges that we have. Obviously what we do in the detecting people, treating them, but with the numbers going, incredible challenge. So the next part of the this presentation is looking at the health economics, and what we've done is looking at, we've just said prevalence and numbers, but what are the effects of vision impairment and blindness? And so two measures that look at that, the DALY and the QALY. So looking at how does vision affect the activity and participation of people related to vision loss. And it can be looked at for the cost per DALY and per QALY of delivering and using ICARE services. Importantly, we need to look at the WHO diagram of health conditions. Obviously, we're looking particularly at vision. So for the functions and structure, the visual functions, visual acuity, and so on. The activities are things that are impacted by the vision. So just things looking at a whole range of things that we want to be able to do, locating things, identifying what things or who people are, but importantly, the participation. How does the vision impairment affect participation of the things that we want to do? Activities is a whole lot of things that we can just look at and observe, whereas participation, we need to find from people what are the things that are important that they have been affected by their vision impairment. So from visual acuity to the activities to the participation. So the activities are measured in the DALY or disability, obviously, and participation in the impact on vision impairment. So DALY, their disability adjusted life years. So it's not just the disability, but the years of life that might be lost by a disease. Fortunately, with vision, the vision is not going to cause loss of life just specifically due to the vision. So the quality adjusted life year. And importantly, to use these, what is the things that people can't do, the activities, and what are the things that people want to do or need to do that they can't do because of the participation. But we can use those measures to look at the dollar or the rupee cost per DALY or for a QALY. So the disability, the DALY, it's expressed as a number of years lost due to ill health. As I said, for vision, that's not important, but certainly, yes, the years lived with disability. So it's not just having a disability, but the years of life that you have the disability related to vision. So it's the time spent. And for many diseases, it's important the years of life lost and the years with lived with disability. But as I mentioned, it's the disability, years lived with disability. So, for all the different causes, we know about when they might start and obviously continued through life. So there are values from tools that can be used to measure DALY, the DALY. And for a country, we look at a measure for a particular country, the activities and the for activities for the disability, and that looking at that in a population. So you can look at life expectancy, and as I said, for vision, no, but other diseases when life expectancy can be reduced, and look at the disability also for different causes, and get those what the disability weights for people, their sort of the disability are calculated, and the range in measures are from 0 to 1. And examples for blindness and deafness, given that range from 0, obviously the lowest for both blindness and deafness, but for things, dementia is an example where the impact, the participation of people with dementia is obviously much, the effects are much greater, higher. So there's incredible tables with all of these data. So the QALY, as I said, disease burden, both the length and quality of life, where DALY is an individual, but for QALY, it's measuring the effects of interventions, for individual people. So it can have a total measure, but it's gained by using tools to look at that with individual people. And again, perfect health, 1, death, 0. So there's tools to look at the quality of life, many tools that specifically looking at the utility, in this, the participation. So there are some general ones. For vision impairment, what we have now is called the AQAL 7D, the assessment of quality of life, and it has 7 different dimensions. It's been put together from different things, and things like items that are included. This was initially for the VisQual, injury, coping, friends, help with roles, and joining in. So the QALY is, as I mentioned, looking at a cost effectiveness of an intervention. And you can look at the cost per QALY for an intervention. So, what's important? What are the different things that we might need to learn? So the last section, I'll hopefully finish quite shortly, looking at the health economics. And so what we want to be able to get from this is sort of not only improve, but cost-effective outcomes that are equitable. I'm going to look at examples of what are the costs, the cost-benefit analysis of particular products, looking to say, do they work? What's the extent that they work, that change the participation of people, and certainly can be important in allocation of resources. So obviously in health economics, you're looking at the efficiency, effective and cost-effective health services, so that if we're looking very specifically at an organisation, or if we're looking at a region or a country, but can we ensure sort of effective and equitable allocation of resources, of the functioning the healthcare systems, but importantly, improving the outcomes for people with vision impairment. That we obviously look at the cost benefit by interventions. Are they working within an organisation, a country, and importantly for people? So the cost-effective interventions can be the cost per QALY for different types of conditions, just listing a whole lot of those there. Obviously, retinopathy of prematurity, diabetes, cataract surgery, and so on. But you can look at, whereas with disability, and there can be sort of QALY looking at vision impairment, we can look at specific diseases to look at, have a publication here on looking at the cost per QALY for people with diabetic retinopathy. What change can we make and how much does it cost? this was interesting. Some research looking at the direct costs, and these are available quite often for countries or different states, looking at the costs that it takes to provide services. So all the different things, inpatients, outpatients, health personnel, aged care, people not being referred, and what the costs and so on. So, and look at research at the bottom, unfortunately fairly small, but these are the direct costs, so that the providers, the government is having to put. But one of the barriers for people with vision impairment is the indirect costs. And I was amazed in interviewing people, the Pioneer Hospital where I worked, the cost to people, because for many people, cost is a barrier to seeking services. So for them, not being able to continue working, or having to take time off work to get eye care. For carers, obviously for devices and things like taxes, but it's both the cost in providing the service, but the cost experiences by people. That what are the indirect costs, the things that people will experience. So looking at the QALY measures, the AQAL is the assessment of quality of life, and the 7 dimensions, and they're listed there. The numbers in brackets after each one of those is the number of items in each of those 7 groups. So there's, yes, quite a lot. And with the AQAL, certainly the results that come out of that, what's the impact for people in all of those? How does it affect their participation? Whether it's work, whether it's home life, whatever it is, how can we learn more, not only about the costs and the impact in the population, but for individuals too, or for particular interventions, what will be the things that we can change or improve. And obviously an important thing for rehabilitation, what are the things that we need to work on? So just to finish off, we've got the numbers, needing eye care and the services, and the data on prevalence and causes that, as we talk about globally, regional, and certainly much of it by country as well. But the important thing, the disability and the quality of life, it's not just the numbers. For individual people and for understanding in a population, the disability and the quality of life. And in health economics, we've got a whole range of methods, materials that we can use to assess those. Now, that's to finish off, but I have listed some of the key papers. The 2 in 2021 were obviously the ones I mentioned, just published for the 2010 and 2015 data. But on this list, the IAPB, International Agency for Prevention of Blindness Vision Atlas, on that website has the data for all of those, the public data from all of the publications. There's a massive list, but global, but also regions and sub-regions on the IAPB website. So I would certainly recommend that if you want to access the data. So thank you very much.
Thanks, Jill. Thanks, Jill, for giving that insight to the recent this is vision as well as insight on QALY and DALY. So we open it for questions, and there are a couple of questions I just read out. One question from Dr. Subhadra was like, this is all about population-based data, but what about data from hospitals? How do we use that in our day-to-day practice or in terms of interpretation, what's happening in the community?
Certainly, it depends what the data are needed for. From the population, you need it to look at, what are the prevalence and causes across the population. So when you have those numbers and data from the population, you can then compare what you have in a particular region or country to how many people are seeking care. What care are they seeking? Having the list of prevalence, the causes as well. So those data from both the population and the hospital are certainly very useful to say, are we getting all of those people? What percentage of the population in our region are we getting? So yes, the two sources important to compare.
So Jill, my idea was that, at least the patients who come to hospital, we can think that, they are the ones who are actually accessing service. One, second, they are properly characterized, because when we see in the population, we are doing a sort of a basic survey. So we may not be getting the exact diagnosis and exactly like, will this patient benefit from surgery or not? For example, you say corneal scar. So in the survey, you will only say corneal scar. But in the clinic, it comes like this corneal scar is not amenable to surgery. So actually, there will be many more corneal scars, but they are not the ones who are going to get surgery. So I think the hospital-based data also should be simultaneous, because these are the patients who are actually coming, they're motivated, and they are properly characterized for the disease in detail.
So
Yeah, and
yeah, Jill, go ahead.
Yeah, sorry. I think absolutely critical to use both, but I think that comparison, having both of those data is absolutely critical to say, who am I getting? Is it particular causes, particular age groups, gender, or am I getting them from some regions but not from others? It might be, like urban and rural areas. So both of those data are, I agree, absolutely critical.
Rohit, can I
answering to that question, Subhadra, just one comment on that question is like, we are talking about now ocular morbidity, and I think hospital data at this point in time, we have only hospital data to talk about ocular morbidity. So both data are important, population and hospital can sometimes be a surrogate of population-based data also. Sorry, Dr. Das, over to you.
I had a question to Jill, and Rohit also can answer. Look at the big data, Jill, larger data of, let's say, 1 million data of Prasad over years. We will still call it a proportion or a prevalence, because that causes a lot of problem for us. When I wrote a prevalence, people object to it because last data like a population. What will you say? Let's say we have got 1 million data from vision centers of Prasad and want to analyze and publish. So we'll call it prevalence data or proportion data.
I think it's important, similar to sort of, I think what I might have said, is to know what are the causes and information about the patients who come, for example, those very large numbers to vision centres, but also with the data of causes. It's that having the available data, absolutely critical to collect it, from LVP, looking at obviously all the different levels of service, and certainly with the data in the EMR now that the data are there to be able to do that comparison. And certainly for LVP, there's the Indian data that come from the global burden of disease, but there's been a number of studies done relatively recently to look at what the prevalence and causes and who's impacted by vision impairment. That population data are certainly there, but absolutely critical. It's not just looking at the numbers that are there, but yes, certainly the services, who uses them, what do they need?
Jill, my question was that on the data, on the big data from hospital comes or different age groups, will categorize them under a population, under a prevalence data, or categorize as a proportion of disease data? Because hospital populations are different than a population actually.
Dr. Das, just to comment on that, I would consider it as a proportion of the patient's proportion right now, because it's not a very cross-sectional kind of data.
Okay, this is my question was, we'll call it a proportion or a prevalence, yeah.
Yeah, I think it is really very important, the limitations, if you're looking just at hospital data, to know the prevalence and causes, because we know not everyone who needs eye care does come. And I know I've done some examples in different countries, looking at prevalence and looking at the number of people using eye care services. And the gap is different in different countries and different regions. But yeah, absolutely critical data from hospitals and other areas of eye care, but it's not giving you an overview of all the causes, the people who come and don't come necessarily, but it needs to be the hospital data compared to the population data.
Before we move, Arnaz, do we have time for questions, more questions?
You can take one last one, Dr. Rohit.
Okay, so one question is, most of the questions I think were answered. One question I will take, last question, is why low income countries has high blindness compared to high income countries? This is by Chiti Simran. Jill, you want to answer that? Why the prevalence is higher in low income countries compared to high income countries?
Being very general about that, there's certainly, you can look at specific examples, but the availability of eye care services, the availability of the range of medical professional eye care staff, the methods in detecting and referring people. So yes, it's certainly a common thing across different levels of countries, socioeconomic things as well as the regions, most definitely are related, and in to look at
Jill, we have lost, I think.
socioeconomic, usually quite different to the higher income.
Thanks.
Rohit, 1 second before we wind, can we take Surya's question? I would like both Jill and Vijaya, who's also here in this, to answer Surya's question about how we can do more on health economics and cost effectiveness in general for all our studies. Rohit, can you just read out his question?
Yeah, so the question is like, do you think it's a time to do cost benefit analysis of common treatment surgeries in ophthalmology? So I think, Surya, just there are multiple costing, like cost minimization, cost effectiveness, cost benefit, and cost utility. There are 4 different terminologies. So cost benefit is different than cost effectiveness. Probably, I think, Jill, you can tell about like economic studies in clinical patients or treatment. Suppose you have treatment A versus treatment B versus how do we do it in ophthalmology? What do we do it?
Yeah, I think, yeah, certainly critical and important. The tools are available to do that. Certainly disability is important, understanding, what people can do or not do, but the critical thing for most people is the participation, looking at the quality of life. What difference do individuals have, because you can't judge it for a particular cause, a particular level of vision. It's, we just talked about socioeconomic, but looking at the quality of life can certainly look at the differences, but the important thing is getting the data from a particular population or group of area of people that you might be servicing or not servicing. What do you know? And what is important? Why do some people able to come, other people not able, or don't know, or don't want to come? So it's looking at that, the effects on participation, and what do we need to do? Part of it is certainly ICARE, and part of it is with low vision and rehabilitation services.
And still, I think in the interest of time, we can close it. And probably if anybody wants to ask any question, probably Jill, you can send your email ID so that people can send more questions to you.
Yep, sure. Happy to answer anything. Yes, by email.
Thank you very much. Thanks, Raja. Thanks, Sarnas. Over to you.
Yeah, and can I say, I hope sometime travel is going to be possible. I'd love to be back and working face to face with you all.
Yes, Indrajit Kaur, we are missing you here.
Thank you.
Thank you, Dr. Jill Keeffe, for taking the time out today and addressing everyone. Thank you, Dr. Rohit, for your time. Thank you, Dr. Raja. Thanks, everybody.
Our Indian name is Jasprit Kaur.
Yes.
Okay.
Thank you. Thank you all. And please do follow IHOPE on LinkedIn and Twitter. We are active on social media. Thank you.
Thank you. Thank you so much.
Yes, no more government going to charge the money.
Thank you and goodbye.
Thank you. Have a nice afternoon, evening, Jill.
Yeah, thank you.